She's one of the vascular surgeons at UCSF, by far the best one. And she's going to be talking today about retroperitoneal access in patients with prior abdominal operations. So, thanks.
Thank you. Is it the green to go forward? Okay. Hi, good morning. Thank you for that very kind introduction. I'm Clara Sanches. As he said, I am one of the vascular surgeons. I'm sort of early in my career, and so the spine team has been keeping me pretty busy with a lot of anterior exposures. And some of them are super straightforward, and some of them are a little bit less so and require a little bit of forethought. So I just want to talk about some of those less straightforward approaches. Obviously, the spine itself has many other thoughts that you guys will have to focus on separately. I have no relevant financial disclosures. If anyone wants to pay me for something, please let me know. But I'll start with just talking about what my preferred approach is. So for most of the multi-level anterior approaches, I would prefer a left perimedian incision. I go about 2 fingers off the midline just to make sure we have sufficient fascia to close. And then I like to mobilize the rectus muscle medial to lateral in order to avoid denervation. You can see a diagram of where the nerves are coming in from the intercostals around, from lateral. So if you are able to sweep the muscle medially, you can avoid some of like the pseudo hernia complications that you can get long-term from rectus muscle denervation. The visceral sac, in contrast, is mobilized laterally to medially, and I just sweep the ureter with me so that I don't even have to worry about it. And you are, voila, right there. In most patients, we can get 3 to 1 very easily. In thinner patients, sometimes you can get up to L2, but I never promise that because I don't want to overpromise and underdeliver. Some of the common alternative approaches that we do, just single level, transverse fan and steel works great. It's very cosmetically appealing. You've got low hernia rates from fan and steels. But if you want to get higher, L1 or T12, whatever, really a lateral thoracoabdominal incision is going to be necessary because it's hard to get up that high with all of the organs you don't want to move around in your way. So when I'm thinking about prior abdominal procedures and sort of my thought process as I approach these patients, a complete abdominal and pelvic history is pretty essential in order for me to know how difficult something's going to be, how much time I need to devote to it, and what my sort of risk of getting into the transperitoneal space is during this process. So I have sort of classified in my mind the less problematic and the more problematic types of procedures that are relevant in someone's history. Things like liver surgery, gallbladder, foregut stuff, the bariatric surgeries, most things in the midgut, so, ileal resections or ileostomies. Most of those things are going to be out of your way, not really a big deal. The open inguinal hernias are kind of irrelevant. You can stay out of that scar pretty easily, and that mesh doesn't come up high. And then abdominoplasties can be a little bit annoying in the superficial, but are generally not difficult in the deeper dissection, so that keeps you out of the danger zone. More problematic are things that are going to be sort of touching the retroperitoneum. So any rectosigmoid resection I would want to know about beforehand because it might be a little bit more challenging, and I might want to go up higher so I can get a cleaner plane. A left-sided colostomy, I've never done one with a left-sided colostomy. I'm not sure I would agree to do one, but you have to be ready to have all of the colon and its bacteria in your field because it would be pretty hard to separate from the incision on the left side. Urologic and GYN procedures and any retroperitoneal dissection might be a problem. The ventral hernias sometimes are, sometimes aren't. The extent of the mesh is really the important factor for whether this is going to be a problem or not. Any aortoiliac surgery is probably going to make it fairly prohibitive to do this, but not always. It depends a little bit on the extent of that surgery. And then pelvic radiation is probably the most hard to predict and potentially dangerous of these. So when you have someone who's had multiple prior abdominal surgeries, this is probably someone I would like to see beforehand. I'd like to see them in my clinic. If they have a bunch of stuff going on, especially large hernias, I'd like to see a real CT abdomen pelvis so I can assess what the abdominal wall looks like and have a little bit more of a predictor about where I'm going to be safe and where I'm not going to be safe. And then when I'm seeing them, what I'm actually looking for is to see sort of the suppleness of their skin on the abdominal wall, what degree of scarring, the position of the scars. And then sometimes I can feel the extent of the hernia mesh and I can just say, oh, this is going to be totally fine. I'm not worried. So history that may be fairly prohibitive. Pelvic and retroperitoneal radiation is often sort of a wild card because some people have it and it's not that bad, and other people have it and it feels like you're trying to get through cement. Prostate brachytherapy, you should think of as not this problem because that's typically far from where I need to be. A large unrepaired ventral hernia or with a loss of abdominal domain is I wouldn't touch that. And then if they have a really large hernia repair with mesh extending past the semilunar line, you might find that you really struggle to get into the retroperitoneal plane there. So I just have a couple examples. This is someone with loss of abdominal domain. I wouldn't touch either side of that abdomen. I would say you're really kind of prohibitive there. There's no way that you're going to do this safely. You're going to be in amongst the bowel, and then when you try and close, you're going to want a huge general surgery procedure to actually get this to close and heal. And then this is an example of, I think, the only hernia mesh that really made us stop and not complete. You can see the mesh lines all the way past the semilunar line and then goes onto the psoas itself and is basically touching the vessels. And this can be super stuck, super difficult to get off, and you can definitely cause some major vascular injury there. So this is one of those that, perhaps you'd say this is not worth it, or I'll do the lowest level from the other side. So just some keys to success when I'm thinking about it. If there are prior scars, it's actually can be quite important to choose your skin incision appropriately. If you have too narrow a band between scars, you have a higher likelihood of necrosing that skin and ending up with this horrible wound on the abdominal wall. If you then choose a scar that's not in the exact position you want, it's much safer to just raise a subcutaneous flap in order to lateralize your position on the fascia as desired. You may choose to mobilize the rectus lateral to medial if you need to. Again, you have some risk of denervation and some risk of some, essentially donor site morbidity in the long term, but overall it's fairly well tolerated. So if you need to do that in order to get past a hernia mesh to get into a safe plane, that certainly is an option. And then anytime you're going into someone's case knowing that there's going to be retroperitoneal scarring, I think that you need to have a little bit of thought about what you're going to do if you have a problem. And so I most worry about mobilization of the iliac vein, which I'm sure most everyone is the most scared of. This is not someone that I would do a small incision on. I like my small, cute incisions for the 1 and 2 levels so that the patient has sort of the easiest time healing. But if I know that there's retroperitoneal radiation, they've had multiple retroperitoneal surgeries, I'm going to make that a larger incision from the beginning. I demand that there's blood in the room by the time I'm opening fascia, just to make sure that if I cause a problem, the anesthesiologist can work with me. And I really like to have a pretty open, active communication with anesthesia about what I'm expecting and what I'm seeing in the moment. And then if I'm doing one of these cases, I like to do it with an assistant who is prepared, has the understanding of what we're doing so that they can help me control any bleeding with sponge sticks or Kittners if we get into trouble and I am needing to do some major mobilization in order to repair. I've had a few people ask me over the last year about ureteral issues. I've never really had an issue with the ureter because if you keep it with a visceral sac, you don't have to dissect it, you don't, devascularize it at all, and you can kind of ignore it for the most part. The only case I've really had where it was a real problem was a prior aortoiliac surgery where they'd had, the replacement of their common iliac with a Dacron graft for an aortic aneurysm. And that was very, very tough to get off of the vessels in order to mobilize further up. So we had to just stop at L5, S1. We were not able to continue the dissection further up because once you injure a ureter, you're really asking for a lot of trouble in the long term. So that may be something that you say this is not safe and you stop. I've been asked a few times about ureteral stents. I definitely would consider it if I've been in the retroperitoneum before. But as we know from a lot of literature in general surgery, stents will help you identify the ureter and it will help you identify that you've injured the ureter, but it actually does not help you reduce ureteral injuries. So all in all, I've never asked for stents. I've never regretted that so far. Time will tell. A few times, right-sided access has been the better way, especially if they've had a bunch of surgery on the left side. I think it makes minimal difference to the L5-S1 level, so definitely if you're going to do a single level and you think you might be back there one day, that would be a nice place to start. But if you've had multiple other operations and the right side would give you a clean plane, you can do that. L4, L5 you can get to, but it gets a little bit challenging to get any higher because the IVC just doesn't forgive you and doesn't shove over as easily as the aorta. The aorta will take, a lot of stress without any issue, but the IVC is less tolerant of that kind of mobilization. Overall, access-related complications are pretty low in anterior approaches, especially in high-volume centers. This is a paper in the vascular literature of about 700, who did about 700 patients a year at their high-volume center, and they have a very low rate overall of vascular injuries and major complications. In our own series that we looked at, we have shown that patients with multiple prior abdominal surgeries do have an increased risk of hernia formation after their anterior approach, so that's something to keep in mind. But overall, the complication rate was not higher in our series in patients with prior abdominal surgeries. I would just put a little plug in for when you're closing this, if you want to reduce your hernia risk. This is like the only real randomized controlled trial that's been done on how to avoid hernia formation after opening the rectus sheath. And basically, we should be using a smaller needle, slightly smaller sutures, and much closer together bites. And this has been shown to significantly reduce your hernia rate. So especially in someone with multiple prior abdominal surgeries, I would think about doing this. This is what I do for my own patients after aortic surgery and such. So just to tie everything together, I think a very thorough abdominal and pelvic history is very important for preoperative planning so that you don't have as many surprises with how long something's going to take, whether you're going to have to abort, some of the levels or all of the levels. Most patients can still get an ALIF safely. There's been relatively few that I or my partners have seen in clinic that we've said, no, I wouldn't touch this. But you should have some thoughtful planning for your incision position, your incision size, to decrease your difficulty. And then atraumatic closure techniques can potentially decrease your risk of post-ALIF hernias. Thank you for your attention.